Hi guys. So we're going to talk in this video about OCD and related disorders, and those related disorders are body dysmorphic disorder and hoarding disorder. And we'll talk about the overlaps among those three disorders and also about the overlap that we'll see with a lot of the anxiety disorders that we talked about in the last chapter. So before we go any further, I would love for you to just take a moment and to think on your own. So maybe even pause the video here and think on your own about what elements these disorders share with anxiety disorders. So from your textbook reading, which hopefully you've already done. And then where are there elements that are different from the anxiety disorders? Keeping in mind that once upon a time, OCD, not that long ago actually, OCD would have been, was considered an anxiety disorder, and it's only more recently that we have differentiated it, and we'll talk in a moment about why. But this is a good moment to just on your own kind of do some of that critical thinking, and then also thinking about how body dysmorphic disorder and hoarding disorder are related to OCD and why we group these together. So pause this here, think about that a little bit, and then we'll continue. So we actually just said that. So let's think first about the similarities between OCD and anxiety disorders. As many of you noted in the last chapter in your discussions, women are diagnosed with anxiety disorders at greater rates than men are, and that is true with OCD as well. And the onset for OCD is typically either the kind of two different scenarios that we usually see. Either it's before the age of 10, so we see children diagnosed with obsessive compulsive disorder, or we see onset in late adolescence and early adulthood. It's less typical to see onset in later adulthood, though that can happen, but the most typical is either in childhood or in early adolescence. And the prognosis and the trajectory is a little bit different. That when we see onset in childhood, a lot of those children will have a period of OCD that then dissipates, it goes away, and they don't wind up with adults that have any struggles with OCD. When we see onset in late adolescence or early adulthood, that's more likely to be something that the person at least needs to be aware of in some way going into adulthood, though treatment is very effective. And it may be that they don't have later problems once treatment happens, but it may be something where they're always at increased risk compared to the general population. The other thing that's very similar to anxiety disorders is the co-occurrence with major depression, where 2/3 of people with OCD also have major depression or will have an episode of major depression at some point. And those numbers look very similar to what we talked about with anxiety disorders. And then, that treatment that we talked about in the anxiety disorders chapter, Mauer's two-factor theory, right? So it's not just treatment, it's explanation of etiology that then gives rise to how we might approach treatment. If you didn't quite understand Mauer's two-factor in the anxiety disorders chapter, this is another opportunity and a really important one. If you're going to understand the treatment for OCD, understanding its grounding in Mauer's two-factor is really important. But in the coming chapter, we're also going to talk about Mauer's two-factor again, and so that may indicate to you that it's something that really is important to understand. So please, post questions in the discussion if that doesn't feel comfortable to you completely. We also have a really high rate of heritability that's similar to anxiety, and so 30 to 50% of whether one develops OCD is probably able to be connected back to genetic factors. So that lots of similarities with anxiety disorders, but there are differences, and this is why we separated out, or some of these differences are an explanation for why it's no longer considered an anxiety disorder. So the rates of anxiety disorders we talked about in the last chapter, the prevalence rates, were much, much higher than those of OCD. And so with OCD, we're talking about a 2% prevalence rate, so about 2 out of 100 people. And so it's one of the lower incidents, certainly compared to the mood disorders and the anxiety disorders. This is much lower than what we talked about in those chapters. So about 2%. And it is often a chronic lifelong disorder. Not always. right, as we talked about just a moment ago, and treatment will make all the difference. People who don't have effective treatment for OCD are likely to have OCD interfere in their lives throughout their adulthood, especially with onset near adulthood. Whereas with treatment, it may not, it may be something that doesn't interfere with life at all. And so it's one of those cases where treatment makes all the difference. The other thing that's really different is in the anxiety disorders, we talked, cognitive behavioral treatment really focuses on the importance of distraction and suppressing anxiety. I often talk to patients about letting waves of anxiety wash over them and trying to not attend or ignore it. With OCD, efforts to suppress or ignore obsessive thoughts paradoxically increase them. So telling somebody to ignore their obsession, and that's the only advice they get, actually makes those thoughts more likely. Excuse me. The other thing that we see that's different between OCD and anxiety disorder is this how much you understand about the problematic thinking and compulsive and behaviors. So often people with anxiety will be able to tell you, I know nothing bad's going to happen, but I can't stop worrying that it will. Whereas with OCD, the person really has a poor ability to know when their behavior, their compulsive behavior, like hand washing, for example, has been enough. And so it's not that they're saying, I know it's enough, sorry, I got distracted by whether my mic was covered. It's not about whether they know it's enough, or they know it's enough and then they stop or can't stop. It's that they truly don't understand whether it's enough. And then we're going to talk about, in the next slide, details about biological etiology, but we do understand that the biological etiology of OCD is really important, and that there are certain brain areas that seem to be more active when the person is in a situation with stimuli that provoke symptoms as opposed to stimuli that don't provoke symptoms. So let's look at this. And I need to say, I grabbed this image. I think it's a useful image. But I do object to their use of the word normal brain. I much would prefer if they use the word typical brain here. And so I'll just say that. But the information I think is useful. So I do want to take a look at it. And I want to start down here on the lower right, actually down here on the lower left-hand side. So we'll start with the basal ganglia, which is this purple area here. And in a typical brain, the basal ganglia controls movements, thinking, judgment, and does that in a way that allows us to start and stop behaviors easily, depending on whether they're needed or not, whether they're responsive to the environment in meaningful ways. In somebody who has OCD, what we see in this brain area is that it causes reflexive or repetitive behaviors, that it seems not to be responding as much to the environment and the environmental demands, but just to be almost on an automatic loop of some kind. And then we have come up just a little bit to this, right, to this green area around the basal ganglia, the caudate nucleus, which is really important for several disorders. In a typical brain, the caudate nucleus is charged. Its job is to filter information, remove unwanted thoughts, essentially to keep us on track and to keep us task focused and kind of keeping our thoughts relevant to what's actually happening around us. Whereas with someone who has OCD, the caudate nucleus just fails to do that. It doesn't filter out anxious thoughts and doesn't do a good job of saying that thought isn't relevant to what's happening here. Let's filter that out. And so then thoughts are being processed that ideally shouldn't be processed. And then we come up to the cingulate gyrus. And you'll notice we're coming like in higher and higher brain regions here. So from more primitive to more sophisticated. The cingulate gyrus, this blue area up here, right, it tends to be a connection between the lower brain regions and the cerebral cortex. And in a typical brain, it adds emotional responses to thoughts. So you have a thought of, I don't think I washed my hands enough, right? And all of us are thinking a lot about hand washing right now. I don't think I washed my hands enough. And then, the emotion that is attached to that is neutral. Okay, so let me wash my hands a little bit more. Or the emotion that's attached to that is positive. Okay, but I can use some hand sanitizer or whatever it is. But with someone with OCD, the cingulate gyrus seems to more routinely add emotions like disgust and guilt to anxious thoughts. And so you get anxious about whether you washed your hands enough, and then you immediately have these very strong negative emotions that are connected to that, which then makes it much more difficult to make kind of logical decisions about it. And then we come up to the cerebral cortex, right? And especially the frontal lobe. The orbital frontal cortex is what you and I usually refer to as the frontal lobe. In a typical brain, it integrates all of the information, our sensory information, the information coming from other brain regions to make decisions that anticipate reward and punishment. So like, I think that would be a good choice, or I think that would be a bad choice. I think that'll work out for me. I think that won't work out for me. In somebody who has OCD, this frontal lobe is more likely to detect an error where there isn't one, and then to send worry signals, right? And so you go to make a decision that I'm done washing my hands, and then the detection of error is, but maybe I'm wrong. Maybe I'm wrong. And so a lot of the experience of OCD is one of doubt. How do I know? How do I know I did that well enough? How do I know I turned the oven off? How do I know I locked the door? And so that worry signal is about detecting the possibility that you've made an error, a thinking error. And so if we combine all of these, the worry about thinking errors, adding disgust or guilt to the idea of those errors, not being able to stop behaviors once they start as well, having more anxious thoughts than you should, right, which sounds like an anxiety disorder, but if we add it to all these other things, it winds up with a very particular set of behaviors. And these behaviors, right, hopefully you're already familiar, but quickly, obsessions are the thoughts and compulsions are the behaviors. And the behaviors often are aimed at quieting the anxious thoughts. And so take a moment, this might be a good moment to pause again and look at this and think about what you already understand about OCD in terms of the elements of the symptoms, the behaviors and experiences, and to think about how they connect to these different brain areas. Okay, and we're going to pause there and have a different video about treatment.